Okay, starting with irritable bowel syndrome. NICE 2018, 2008 reviewed in 2017. The treatment of IBS should be considered if the patient has had the following for at least 6 months: abdominal pain, or bloating and or change in bowel habit. Positive diagnosis of IBS should be made if the patient has abdominal pain relieved by defecation or associated with altered bowel frequency stool form, in addition to two of the following four symptoms: altered stool passage, straining, urgency, and community evacuation; abdominal bloating, more common in women than men; distension, tension, or hardness; symptoms made worse by eating; passage of mucus. Features such as lethargy, nausea, backache, bladder symptoms may also support the diagnosis. Okay, what are the red flag features? Rectal bleeding, unexplained unintentional weight loss, family history of bowel or ovarian cancer, onset after 60 years of age. So these are red flag features. Investigations, we consent for full blood count, ESR, CRP, celiac disease screen. First line pharmacological treatment can be antispasmodic agents, constipation, laxative, but avoid lactulose. Diarrhea, loperamide is first line. Okay. Second line treatment, low dose tricyclic antidepressant and amitriptyline 5 to 10 mg are used in preference to selective serotonin reuptake inhibitors. Other management can be psychological interventions. If symptoms do not respond to pharmacological treatments after 12 months and who develop a continuing symptom profile refractory IBS, consider referring for cognitive behavioral therapy, hypnotherapy, or psychological therapy. Complementary and alternative medicines do not encourage use of acupuncture or all these things. General dietary advice can be regular meals and take time to eat. Avoid missing meals or leaving long gaps between eating. Drink at least 8 cups of fluid per day. Restrict tea and coffee to 3 cups per day. Decrease intake of alcohol and fizzy drinks. Consider limiting intake of high fiber food. Decrease intake of restrained starch of and processed food. Limit fresh food to 3 portions per day. For diarrhea, avoid sorbitol. For wind and bloating, consider increased intake of oats. IBD. Differences between ulcerative colitis and Crohn's are summarized below. So these two are very important. Inflammatory bowel disease. For the features, for ulcerative colitis, blood diarrhea is more common, and abdominal pain in the left lower quadrant is tenesmus. And for Crohn's disease, usually non-bloody, weight loss more prominent, and upper GI symptoms, mouth ulcers, perineal disease, all the things can happen. Abdominal mass palpable in the right iliac fossa, so it's like totally in different places. Extraintestinal complications, PSC complications can be PSC with ulcerative colitis. Okay, risk of colorectal cancer high in ulcerative colitis than Crohn's disease. Inflammation always starts at rectum and never spreads beyond ileocecal valve. Continuous okay, this is the pathology. So complications in Crohn's disease can be obstruction, fistula, colorectal cancer. Okay, so pathology, inflammation always starts at rectum and never spreads beyond ileocecal valve. So it's still that continuous disease associated with Pianka antigen. Okay, and here lesions may be anywhere from the mouth to the anus. Skip lesions may be present associated with ASCA, antisaccharomyces, whatever. Histology, no inflammation beyond submucosa, and this is transmural inflammation in all layers from mucosa to serosa. There will be goblet cells and granulomas. And here in ulcerative colitis, there is no inflammation beyond submucosa. Inflammatory cell infiltrate in lamina propria. Neutrophils migrate through the walls of the glands to form crypt abscess. Depletion of goblet cells, mucin from gland epithelium. It continues here. What you'll see is for ulcerative colitis, widespread ulceration with preservation of adjacent mucosa, which has the appearance of polyps, pseudopolyps, and so ulcerative pseudopolyp. And here there'll be deep ulcer, skip lesions. So this is not ulcerative, no use. Barium rheology, you'll see barium enema, loss of obstructions in ulcerative colitis, superficial ulceration, pseudopolyp. Long-standing disease, colon is narrow and short, brain pipe colon. And for Crohn's disease, small bowel edema, high sensitivity and specificity for the examination of terminal ileum, strictures, cantors, string sign, proximal bowel dilatation, rose thorns, ulcers, fistula. Don't give antidiarrheal treatment for acute colitis. It can cause toxic megacolon. Diagnosis: people with any of the following lower GI symptoms that have been present for at least 6 weeks should be suspected for IBD. Abdominal pain or discomfort, bloating and change in bowel habit. 6 weeks. Okay. Fecal calprotectin alongside clinical assessment may be useful to distinguish between suspected IBD and non-inflammatory bowel disease such as IBS. So this is very important. Calprotectin is a protein. Its presence in feces indicates the migration of neutrophil to the intestinal mucosa. So migration of it's a protein, and the presence of it will indicate that there is migration of neutrophils in the intestinal mucosa, which occurs during intestinal inflammation, including inflammation caused by IBD, and it may also be detectable in celiac disease, infectious colitis, necrotizing enterocolitis, intestinal cystic fibrosis, colorectal cancer. It's very important. Okay, although a relatively new test, fecal calprotectin is regularly used as an indicator for IBD during treatment as a diagnostic marker. Okay, type of ulcerative colitis can be, you see, pancolitis, the whole colon, extensive colitis, and then distal colitis. This proctitis is just the rectum part, proctosigmoiditis, distal colitis. For ulcerative colitis, the treatment can be divided into inducing and maintaining remission. So how do you induce the remission? When the patient comes to you, treatment depends on the extent severity of disease. Rectal aminosalicylate or steroids. For distal colitis, rectal mesalazine is superior to rectal steroid. So mesalazine is better. Mesalazine will be good. Rectal mesalazine. So this is the one inducing remission. Rectal mesalazine. Okay, and oral aminosalicylate or steroid. Severe colitis should be treated in hospital. So start with mesalazine. One will be rectal mesalazine. Okay. Next will be steroid you can give. Okay. Maintaining remission is different. Oral aminosaccharide, example mesalazine as well. So mesalazine has the side effect of acute pancreatitis. You can remember that. Oral, versus rectal. So in severe ulcerative colitis, patients treated with IV steroid, fluid, subcutaneous heparin, elemental diet. Patients should have daily examination monitoring, including review by surgeons, blood tests, stool culture, heart rate, temperature, and abdominal x-rays. Okay. True love and weight criteria for colitis. Okay. So this criteria can be like this: that stool frequency less than 4, temperature febrile, heart rate normal, hemoglobin with 11, acid less than 20 is mild. 4 to 6 is moderate, and severe is more than 6. Temperature more than 37.8, heart rate more than 90, hemoglobin less than 10.5, ASM more than 30. True love and weight criteria. Okay. Ulcerative colitis and colorectal cancer. Risk of colorectal cancer is 10 to 20 times that of general population. Risk of increase mainly related to chronic infection. Worse prognosis than patients without UC. Lesion may be multifocal. Patient with concomitant ulcerative colitis and PSC are at risk of developing colonic cancer, and it is recommended that they may be screened annually with colonoscopy. Patients with extensive ulcerative colitis should be screened 8 to 10 years from the onset of symptoms. Colonoscopy should be performed 3 yearly in the second decade, 2 in the third decade, yearly by the fourth decade. Okay. Patients post-liver transplant for PSC should still have yearly screening. Each case should be considered for the benefits risk of the colonoscopy. Factors increasing risk of cancer: disease duration more than 10 years, patient with pancolitis, onset before 15 years old, and unremitting disease, poor compliance to treatment. Crypt abscess are sometimes seen in Crohn's disease as well, but they are more commonly associated with ulcerative colitis. Okay. Crohn's disease commonly affects the terminal ileum and colon, but may be seen anywhere from mouth to anus. Okay, so blood will be, you'll see CRP correlates well with the disease activity. So there will be increased CRP. Endoscopy, colonoscopy is the investigation of choice. Features suggest of Crohn's disease include deep ulcers, skip lesions, deep ulcers. Okay. Histology: inflammation in all from layers from mucosa to serosa, the presence of goblet cells and granulomas, GG. GG. Okay. Small bowel edema, high sensitivity and for examination of the terminal ileum, stricture cantor string sign, proximal bowel dilatation, rose thorn ulcers, fistula. All these things can be there. So normal, you see there are some pictures, and then Crohn's disease, you'll see cobblestone appearance in thickened wall, all these, and also requires loss of ostration. You see there's no curves, crypt distortion, pseudopolyps, ulceration, so all this. Okay. For management of Crohn's disease, so patients should be strongly advised to stop smoking. Some studies says an increase in risk of secondary relapse to NSAID and the combined OCP, but the evidence is patchy. Inducing remissions. How do you do remission in Crohn's disease? Steroid. First line management as monotherapy. So the difference between Crohn's and ulcerative colitis is that management in Crohn's you prefer steroids. How do you remember? Crohn's steroid starts first. Ulcerative colitis, how do you remember? So this may not be the good way. So Crohn's steroid. Just remember like this. Crohn's steroid is the. It sounds like an asteroid. Crohn's steroid. So starts with steroid. The other one is the other one, right? So first line of management is monotherapy. ASA if steroids not tolerated, not for severe disease. Okay. Consider budesonide as for a first presentation or a single inflammatory exhibition at 12 months. Okay, add-on treatment. If still no remission, then azathioprine. Then Mrcp, then methotrexate is used in patients intolerant of azathioprine or refractory disease, usually given intramuscularly but not effective for maintaining remission. Significant anemia is a contraindication for methotrexate. Infliximab, adalimumab could be considered for severe active Crohn's whose disease has not responded to conventional therapy, useful in refractory disease and fistulating Crohn's disease. Patients typically continue on steroid as a therapy and methotrexate. Enteral feeding may be used in addition to or instead of some other to induce remission. How do you maintain? Maintenance would be option include both no treatment and treatment. If treatment, offer azathioprine or marcaptopurine. So, okay. Consider methotrexate if needed for inducing remission or intolerant. Do not offer steroid to maintain remission. So steroid is kind of a no for maintenance. Okay. And how do you maintain that? That one was for Crohn's ulcerative colitis was mesalazine again for maintenance, just oral ones. Aminosalicylate. So surgery, around 80% of patients with Crohn's will eventually have surgery. So this is an example of how Crohn's and ulcerative colitis look. It's like all inflammation here is like patchy inflammation here, there, stricture. Okay, colorectal cancer, also very important. So for colorectal cancer screening, NICE 2017, most cancers develop from adenomatous polyp. Screening tests in primary care. Fecal immunochemical test, OC sensor, all these. Fecal occult blood detection. Okay, fecal occult blood testing is the only method to have been proven to decrease mortality in trials. Sensitivity can only increase by DNA analysis for the APC gene. If fecal occult blood test is positive, patient will be offered colonoscopy. Patients with high risk of colorectal cancer, IBD or strong family history are offered colonoscopy rather than FOP. CEA are maybe used to monitor for recurrence in patients post-operatively or to assess response to treatment in patients with metastatic disease. So recurrence or response. CEA scan study is a nuclear medicine procedure that uses a small dose of radioactive isotope to image tumors, sometimes invisible to the other diagnostic tests. That isotope is guided to tumors via antibody fragments engineered to seek out and attach to any tissue that expresses CEA. Protein found on virtually all colorectal tumors. CEA blood tests attempt to detect the same protein in blood but often fail to do so due to the lack of sensitivity. So causes for positive fecal blood testing are 2 to 10% cancer, uh, colorectal cancer, gastric cancer, 20 to 30% adenoma or polyps, bleeding peptic ulcer, or angiodysplasia of the colon. So diagnostic investigations, CT colonography if available and done by competent radiology service. If suspicious lesion is detected, offer colonoscopy with biopsy to confirm diagnosis. Colonoscopy to patients without major comorbidities. Flexible sigmoidoscopy, then barium enema for patient with major comorbidity. Staging and grading offers contrast CT chest, abdomen, and pelvis for staging. Offer contrast CT chest, abdomen, and pelvis CT cap for staging. The Duke staging system is widely employed for classifying colorectal cancers and is a useful predictor of survival. Tumor grade and depth of penetration is also important. Duke A, stage 1, defines the tumor confined to the bowel wall. Stage 1 defines the tumor confined to the bowel wall, mucosa and submucosa. Duke B, stage 2, invades through the muscle wall. Stage 3 involves lymph nodes. And after this patient, the patient is at distal sites. Confined to the bowel wall. And then stage 2 muscle wall, lymph node. Okay, stage 4 is metastasized. It's currently thought that there are 3 types of colon cancer: sporadic 95%, FAP less than 1%, HNPCC 5%. Okay, colorectal carcinoma management. Uh, surgical excision is the main treatment. Adjuvant chemotherapy can also be given, like fluorouracil and floronic acid is warranted in high-risk stage 2 colonic carcinoma and all stage 3. The addition of oxaliplatin has been shown to improve survival in these patients in a large study. Adjuvant radiotherapy is used in rectal carcinoma. This is combined with chemotherapy in stage 2 and 3 rectal carcinomas. So adjuvant radiotherapy is used in the rectal carcinoma. This is combined with chemotherapy in stage 2 and 3 rectal carcinoma due to reduce the risk of local as well as metastatic relapse. Prognostic indicators post resection: poorly differentiated histological type, tumor adherent to adjacent organs, bowel perforation, colonic obstruction at the time of diagnosis, venous invasion by the tumor. Prognostic indicators. Studies have shown that sporadic colon cancer may be due to series of genetic mutations. For example, more than half of colon cancer show allelic loss of the adenomatous polyp (APC) polyposis gene, APC gene. It's believed a further series of gene abnormalities, for example, activation of KRAS oncogene, deletion of P53 and DCC tumor suppressor genes lead to invasive carcinoma. Okay, so all these can lead to invasive carcinoma, loss of APC gene, activation of KRAS oncogene, deletion of P53, DCC tumor suppression, all these. HNPCC is an autosomal dominant condition. Is the most common form of inherited colon cancer. So something important, most common form. Around 90% of patients develop cancers, often of the proximal colon, which are often poorly differentiated and highly aggressive. Currently, 4 gene mutations have been identified, including the HMLH1 and HMS2. The Amsterdam criteria is sometimes used to have 8 diagnoses. So, what's the Amsterdam criteria? At least 3 family members with colon cancer. The cases span at least 2 generations. At least 1 case diagnosed before the age of 50. Screening for increased risk group, colonoscopy every 2 years from 20 to age 40, then annually. Check mutation in DNA or mismatch repair gene. FAP. Family ill adenomatous polyposis, FAP. It's a rare autosomal dominant condition, which leads to the formation of hundreds of polyps by the age of 30 to 40 years. Patients inevitably develop carcinoma. It's due to mutation in a tumor suppressor gene called adenomatous APC gene located in chromosome 5. So it's a very important gene, as you can already see. Genetic testing can be done by analyzing DNA from a patient's white blood cell. Patients generally have a total colectomy with ilioanal pouch formation in the 20s. People with FAP are also at risk from duodenal tumors, which is the important cause of death. A variant of FAP called Gardner syndrome and also feature osteomas of the skull mandible can be identified based on oral findings including multiple impact on the supernumerary teeth, multiple jaw osteomas which give a cotton appearance to the jaws, as well as multiple odontomas, congenital hypertrophy of the retinal pigment epithelium. Okay. In addition to multiple adenomatous polyps of colon, thyroid carcinoma, epidermal syndrome, just on the skin. Okay, 2017 recommend the following patients are referred urgently within 2 weeks to colorectal service for investigation. More than 40 years with unexplained weight loss and abdominal pain, more than 50 years with unexplained rectal bleeding, more than 60 years with iron deficiency anemia, changes in bowel habit. Okay, angiodysplasia is basically a vascular deformity of the GI tract which predisposes to bleeding and iron deficiency anemia. It is associated with aortic stenosis. Angiodysplasia is associated with aortic stenosis. It's called Haley's syndrome. Vascular deformity of the GI tract, which is with bleeding and anemia. The association between angiodysplasia and aortic stenosis is thought to be caused by one Wilbrand factor being proteolized in the turbulent blood flow around the aortic valve. VWF is most active in vascular beds with high shear stress as angiodysplasia and differential WF, increasing the bleeding risk from such lesions. Okay, so what do you do for diagnosis? You will do colonoscopy, evacuate bleeding, mesenteric angiography. Management can be endoscopic cautery or argon plasma coagulation. You can use also Traxil like tranexamic acid, antifibrinolytics, or estrogen may also be used. Microscopic colitis, another very important topic. It's defined by the triad of colitis. So watery diarrhea, normal colonoscopy won't show anything. Increased inflammation of the lamina propria of the colon. The disease includes collagenous and lymphocytic colitis. It's an uncommon disease with an incidence of 5 per thousand, 1 lakh per year, more frequent in women, and its mean age is 50 to 68. Associations can be NSAIDs, omeprazole, lansoprazole, ticlopidine, cimetidine. Treatment includes just stopping the offending medication. So these things can actually cause microscopic colitis. All these medications. So just the treatment can really include just stopping these medications. And cimetidine is these ones are important. Corticosteroid, cholestyramine, and bismuth have been used as treatment with some effect. Recurrence, however, does occur. Toxic metacolon is very also important. Usually associated with severe colitis. Colon is dilated when it measures more than 6 cm. Toxic dilation can be treated medically for 12 to 24 hours with IV and rectal hydrocortisone. So IV and rectal hydrocortisone, but if there's no improvement in the triad, if there is then no improvement in the triad of pulse, stool frequency, colon dilatation, then patient should undergo an urgent colectomy. So what do you check for after giving rectal and IV hydrocortisone is pulse, stool frequency, and colon dilatation. So if it's not improving, then go for urgent colectomy, and otherwise there is an increased risk of perforation. In addition to steroids, now acutely anal patient should receive potassium supplementation and thromboembolism prophylaxis, and antibiotics have been demonstrated to help. Okay, topic. Melanosis coli, a disorder of the pigmentation of large bowel wall. Histology demonstrates pigment-laden macrophages associated with laxative abuse, especially anthraquinone as compounds such as senna. So, can happen due to laxative abuse. Cowden syndrome is an inherited condition resulting from a defect in the P10 suppressor gene. Hamartomatous polyp of the GI are often the first manifestation. Hamartomatous polyp, along with characteristic mucocutaneous lesions such as oral mucosal papilloma, palmoplantar keratosis, trichomonas, plenty hair follicle. The syndrome is a different important to diagnose early because of the high risk of malignancy, particularly of the breast and thyroid. Thyroid dysfunction is common even in the absence of cancer. Familial juvenile polyps often results in multiple polyps of the colon, identical to those in found in Gardner syndrome, but also associated oral lesions are absent. We now move to the next topic, which is, of course, pancreatic disorders. Very important. Then we will be left with only liver after this. So, very important topic is an acute pancreatitis. What really happens? It's what we need to know are the causes of it. Alright, acute pancreatitis, the causes are very important to know, and the vast majority of cases in UK are caused by gallstones and alcohol. So, there's a mnemonic for remembering the causes of acute pancreatitis: get smashed, gallstones, ethanol, trauma, steroids, mumps, autoimmune diseases like polyarteritis nodosa, ascaris infection, scorpion venom, hyper TG, hyperchylomicronemia, hypercalcemia. Only one is hypothermia, that's the hypo. Mrcp, drugs like azathioprine, mesalazine, tiranosine, bendoflumethiazide, okay, furosemide, pentamidine, share sodium valproate as well, and high degree of burn of large skin area with significant inhalation injury. So all these things can actually cause pancreatitis get smashed. Okay, so hyperchylomicronemia may be caused by hereditary lipoprotein lipase deficiency and apolipoprotein C2 deficiency. It predisposes to recurrent attacks of acute pancreatitis. Pancreatitis is 7 times more common in patients taking mesalazine than sulfasalazine. Okay, important to remember. Rare features associated with pancreatitis include ischemic retinopathy. So something which we don't remember usually. Ischemic puncture retinopathy, cotton wool spots seen on the fundoscopy, may cause temporary or permanent blindness as well. This condition may be seen following head trauma and in conditions such as acute pancreatitis, fat embolization, amniotic fluid embolization, and vasculitis disease. What are the poor prognostic factors? Branson's criteria: age more than 55, WBC more than 16, urea more than 16, glucose more than 11, albumin less than 30, ALT more than 250, calcium less than 2, LDH more than 350, partial pressure of oxygen less than 8, hematocrit more than 10%, base deficit more than 4, fluid loss more than 6, etc. CRP is now a widely used marker of severity in pancreatitis. Other methods which may have to correlate with prognosis include the Ransom criteria and Apache 2 score. Pancreatitis in the context of HIV infection may be secondary to antiretroviral treatment, especially tenosin, or by opportunistic infections like CMV. So here are the phases of acute pancreatitis. No need to really remember them. Complications are there which may need to be remembered. Types like interstitial, necrotizing, pseudocyst, and necrotic collection. Okay, for chronic pancreatitis. Chronic pancreatitis, which you have to remember as well. It's an inflammatory condition which can ultimately affect both the exocrine and the endocrine function of the pancreas. Around 80% of cases are due to alcohol excess, with up to 20% of cases being unexplained. Features of the chronic pancreatitis is pain is typically worse 15 to 30 minutes following a meal. So after a meal, that's when you have pain. Steatorrhea, symptoms of pancreatic insufficiency, usually develop between 5 to 25 years after the onset of pain. Diabetes mellitus develops in the majority of patients. It typically occurs more than 20 years after a symptom began. After 20 years, really, that's a lot. Okay, investigation and management. Abdominal X-ray shows pancreatic calcification, 30% of cases, very important. CT is more sensitive in detecting pancreatic calcification, and functional test, pancreoloral and lung test may be used to assess exocrine function if imaging is inconclusive. Management can be pancreatic enzyme supplements, analgesia, antioxidants. Limited evidence is there. Okay, pancreatic cyst and pseudocyst. So what exactly is it? Let's study cyst first. Cystic tumor can occur in the pancreas. There are two main types: Serous cystadenoma, benign and remain benign, and mucinous cystadenoma. This may be benign but has potential to become malignant. So cyst, serous. These are actually complications of pancreatitis. Serous cystadenoma and mucinous cystadenoma. So how to diagnose it? Endoscopic ultrasound, not normal ultrasound. CT or MRCP are also diagnostic. Aspiration of the cyst for cytology and carcinogenic embryonic antigen. Management can be mucinous neoplasm. Most patients undergo limited surgery for pancreatic cyst. Okay, now pseudocyst. It's an uncommon complication of acute pancreatitis and a localized collection of pancreatic fluid. So it's pseudocyst, if you have to remember. Localized collection of pancreatic fluid and debris, usually in the lesser sac. They are initially contained within a fragile wall of granulation tissue, which eventually forms a fibrous capsule. So this cannot be diagnosed until more than 6 weeks after the acute attack and may be present with abdominal pain or mass, fever, persistently raised amylase and liver function test. Small pseudocysts usually resolve spontaneously. So most of them pseudocysts usually resolve spontaneously. If it's more than 6 centimeter in diameter, seldom disappear spontaneously and may lead to complications such as hemorrhage and infection. They usually managed by endoscopic or percutaneous drainage or surgical intervention. Serous cystadenoma or asymptomatic pseudocysts can be associated with polycystic kidney disease and von Hippel-Lindau disease. Very important as well. The next will be another important topic of VIPoma is also under pancreas. So all these pancreas stuff together. So in VIPoma, what do you see exactly? VIP is vasoactive intestinal peptide. Source is for small intestine and pancreas. Stimulation is a neural action, stimulates secretion by pancreas and intestine, inhibits acid and pepsinogen secretion. So this is normally VIP. What it does? Okay. So VIPoma, what happens is 90% arises from the pancreas. All the VIPs are in pancreas. Large volume diarrhea, secretory type due to enterocyte stimulation, weight loss, and dehydration, hypokalemia. There's diarrhea, hypochlorhydria, refer to states where the production of gastric acid is low. So what you need to remember is large volume diarrhea, weight loss, dehydration. That's all. And VIPoma is from the pancreas, 90%. Another one is Zollinger-Ellison syndrome. This is also a condition characterized by excessive levels of gastrin, usually from a gastrin-secreting tumor, usually of the duodenum or pancreas. So the weird thing is it's gastrin. It's supposed to be from stomach or something, as you may expect, but it's actually it's a tumor. It's a gastrin-secreting tumor from the pancreas or the duodenum. So around 30% occur as part of the men type 1 syndrome. Okay, so Zollinger-Ellison syndrome, men type 1. Zollinger-Ellison syndrome typically presents with multiple gastroduodenal ulcers causing abdominal pain, diarrhea, and malabsorption. Abdominal pain, diarrhea, malabsorption. So it's similar to all these symptoms. High dose proton pump inhibitor are needed to control the symptoms. So what you see, there is a triad of Zollinger-Ellison syndrome, men type 1. There's gastrin, increased peptic ulcer, pancreatic tumor, epigastric pain and diarrhea, abdominal pain, diarrhea, and malabsorption. So it's very easy and important as well. For diagnosis, you check the fasting gastrin levels. The single best screening test done in 3 different days as the gastrin secretion is pulsatile, and then secreting stimulation test considered positive. Considered positive if there is an increase in gastrin more than 200 after secretin injection. Normally, secretin decrease suppresses gastrin, but in Zollinger-Ellison syndrome, it simply shows that the source of gastrin is not in the stomach, it's in the pancreas. So you give secretin and when still gastrin is high, which means there's an additional source of gastrin that is not in the stomach. It's in fact from the pancreas or duodenum. And for management, if no meds, surgical resection is the cure, and octreotide can be used to alleviate symptoms with interferon and chemotherapy to attempt cure non-respectable tumor. PPI is used to control symptoms in early stage. Pancreatic cancer are an important thing to deal with. Incidence in the West, 10 to 15 cases per 1 lakh, rising to 100 per 1 lakh, more than 70 years of age. Male more predominant. 90% of pancreatic neoplasm are adenocarcinoma that arise from the pancreatic ducts. adenopancreas. Okay. Tumors involve local structures and metastasize to regional lymph nodes at an early stage. Most patients have advanced disease at the time of presentation. Overall survival rate is 3 to 5%, with median survival of 6 to 10 months with no meds. It drops to 3 to 5 months with meds. KRAS is the most common oncogene in this condition. KRAS pancreas. Remember this. KRAS pancreas. Insulinoma are the commonest form of endocrine tumor of the pancreas. Okay, insulinoma is also there. Why are we studying that? Maybe it's in endocrine, yes. So associations of pancreatic carcinoma: smoking with a twofold increase in incidence, chronic pancreatitis, diabetes, hereditary pancreatitis, hereditary non-polyposis, colorectal carcinoma, then multiple endocrine neoplasia, Pause-Joubert syndrome, BRCA2, dysplastic nevus syndrome. Ultrasound and contrast CT are used for diagnosis. Staging can be endoscopic ultrasound, laparoscopy, and with laparoscopic ultrasound will define tumor size, involvement of blood vessel, metastatic spread. Mrcp restricted to palliative care. CA99 ultrasound abdomen is less reliable when the tumor is in the body or brain. Management can be surgical intervention. Represents the only chance of long-term survival, with less than 20% suitable for diagnosis. Eligibility for resection depends on tumor size and invasion of superior mesenteric arterial portal in presence of meds. Radiation chemotherapy are ineffective, so no need to give. Hepatology. Okay, so hepatology, starting with LFTs. Okay, so bilirubin is derived from the breakdown of heme in the red blood cells within the reticuloendothelial system. Unconjugated bilirubin, that is, liver conjugates bilirubin, which makes it water soluble, and it's excreted in the urine. So normal total serum bilirubin is measured. However, the unconjugated is indirect bilirubin, and so there's like both unconjugated bilirubin and conjugated bilirubin. This is called direct, and it's called indirect. Albumin. It's a sensitive marker of hepatic function, but not useful in the acute stages. It has a long half-life, 20 days. Transfers, usually either L9 aminotransfers or aspartate aminotransfers. Rarely does a laboratory literally provide both. These enzymes normally reside inside cell in cytoplasm, so raised levels usually represents hepatocellular. So these are inside the cell, so raised levels should signify hepatocellular damage. ALT is more specific to the liver, and AST is more found in cardiac and skeletal muscle and red blood cells. So LT is like good enough. SGPD, that is. Very high levels, more than 1,000, so this is drug-induced hepatitis. So very high levels of SGPD may include drug-induced hepatitis, like paracetamol, acute viral hepatitis, ARB, or ischemic or rarely autoimmune hepatitis. The ratio of AST to ALT can give some extra clues as to the cause. In chronic liver disease, ALT is more than AST. Once cirrhosis established, AST is more than ALT. So yeah, so once ALT is there, ALT is more than AST. In cirrhosis, AST more than ALT. And the extremes of the ratio of AST and ALT can also be helpful. More than 2, AST is 2. Once more than 2 is just alcoholic liver disease. So AST to ALT more than 2, and less than 1 is just non-alcoholic liver disease. GGT also relates to the bile ducts, typically elevated in cholestasis with elevated ALKP, alkaline phosphatase. But if ALKP normal, suggest induction of hepatic metabolic enzyme, alcohol or enzyme inducing drugs. So GGT and ALP increase in cholestasis. Okay? But if it's only isolated GGT, alcohol or enzyme inducing drugs. Alkaline phosphatase comes mainly from the cell lining bile ducts, but also in bone. So marked increase is a typical of cholestasis of an elevated GGT or bone disorder is a normal GGT. So normal GGT only alkaline phosphatase increase is also for bone disorders. Um, Isoenzyme analysis may help identify cause source. It's physiologically increased when there's increased bone turnover, adolescence, and it's elevated in the third trimester of the pregnancy. Very important. So there's like a table here. Okay, when bilirubin is increased and no bilirubin in urine dipstick, unconjugated bilirubin. Okay, so urine dipstick usually will show conjugated one. So if there is no no bilirubin in urine, it's unconjugated bilirubin. So unconjugated bilirubin is not soluble in water, hence can't appear in urine. So in hepatocellular damage, you'll see AST, OLT plus to very much plus. Cholestasis little or none, infiltration little or none. Alkaline phosphatase will increase in cholestasis, of course, infiltration as well, and bilirubin will increase in all the cases, except for infiltration. Okay, hepatomegaly. Okay, so what are the causes of hepatomegaly? Hepatomegaly cause can be cirrhosis if early disease, but later liver decrease in size. Associated with a non-tender firm liver, malignancy can also be a reason of hepatomegaly. Metastatic spread of primary, associated with hard irregular leverage. Now, right heart failure from smooth tender leverage may be possible. Hepatomegaly plus Dupuytren's contracture plus peritonitis, alcoholic liver disease. So very important as well. Dupuytren's contracture and peritonitis. Other causes of hepatomegaly can be abscess, glandular fever, hematological malignancy, hemochromatosis, hereditary disease, malaria, PBC, sarcoidosis, amyloidosis. Criteria for hepatic encephalopathy: grade 1. Grade 4 can be coma, unresponsive to verbal or noxious stimuli. Grade 3 can be somnolence to semi-stupor, but responsive to verbal stimuli, confusion. Grade 2 lethargy, apathy, and grade 1 trivial lack of awareness. Hepatosplenomegaly. Okay, hepatosplenomegaly. The causes of hepatosplenomegaly can be CLD with congestive, infectious, hematological storage. So for storage, there can be amyloidosis, lactose storage disease, cautious disease. Infection can be like glandular fever, malaria, infective hepatitis, cholera. Um, Congestive can be CLD and portal hypertension, congestive heart failure, congestive pericarditis, and Budd-Chiari syndrome. And hematological can be lymphoma, myeloproliferative disorder, CML, anemia. Okay, alcoholic hepatitis. It commonly occurs after a prolonged period of alcohol abuse or return to alcohol after a period of abstinence. Features can be increased serum transaminase, macrocytosis, thrombocytopenia, poor hepatic synthetic syndrome function, poor hepatic synthetic function, and leukocytosis irrespective of infection. Increased acute phase reactants. AST by ALT is more than 2. The ratio is more than 2. That is SGOT by SGPT more than 2. Liver enzymes do not exceed 500. And discriminant function DF. Malnutrition, junction fluid, jaundice. Malnutrition, jaundice, fluid retention, and encephalopathy are associated with poor outlook. The discriminant function can be used to identify patients for treatment. Those who have DF more than 32 have 1 month mortality rate of 40%. They may benefit from corticosteroid or pentoxifylline. Histology can help to confirm the diagnosis. So DF into PT minus control plus bilirubin. Zeev syndrome. Zeev syndrome is basically occurs in patients with excessive alcohol consumption, with hemolysis and severe hyperlipidemia and abdominal pain. Transient mildly raised bilirubin. It occurs in males and resolves once alcohol consumption is stopped. Okay, so moving to the next topic. Autoimmune hepatitis is a very important topic as well. So autoimmune hepatitis is a condition of unknown etiology which is most commonly seen in young females, and recognized associations include other autoimmune disorders, hypergammaglobulinemia, HLA-B8-DR3, 60% of patients have chronic hepatitis that may mimic viral hepatitis, but without serologic evidence of a viral infection. Three types of autoimmune hepatitis have been characterized according to the types of circulating antibodies present. So the type 1 would be um, type 1 is anti-nuclear antibody and or anti-smooth muscle antibodies positive, ANA or smooth muscle affect both adult and children. And type 2 is anti-liver or kidney microsomal type 1 antibody LKM1 positive affects children only. This is for both adult and children. And type 3 is soluble liver kidney antigen affects middle age, more than 60% remission with steroids, but relapse is 80%, and as a type present all of them. So what are the features that you see in autoimmune hepatitis? It's very important. You will see deranged LFTs and secondary amenorrhea in a young female. So it's more common in young females. Deranged LFTs and secondary amenorrhea in young female autoimmune hepatitis. So features you can see may present with signs of chronic liver disease, acute hepatitis like fever, jaundice, etc. Amenorrhea is common. ANA, SMA, or LKM1 can be positive. And raise IgG level. So which one is what? ANA, SMA is for type 1, LKM1 is for type 2. It affects children only, LKM1, and this one is for both adult and children. Another one is soluble liver kidney antigen. That is for type 3. Raise IgG levels. And in liver biopsy, you'll see inflammation extending beyond limiting plate, piecemeal necrosis for autoimmune hepatitis, bridging necrosis. And management can be steroid, other immunosuppressant like azathioprine, liver transplantation. So for autoimmune hepatitis, the things you need to remember are the features: deranged LFT, secondary amenorrhea in a young female, and the antibodies that are there. Okay, next is non-alcoholic fatty liver disease. This one is now the most common cause of liver disease in the developed world. It's largely caused by obesity and describes a spectrum of disease ranging from steatosis, fat in the liver, steatohepatitis, fat with inflammation. Non-alcoholic steatohepatitis can exist as well. This is called NASH. Steatohepatitis, non-alcoholic steatohepatitis. Progressive disease may cause fibrosis and liver fibrosis and cirrhosis. So these are the ones. NFLD can be divided into steatohepatitis, NASH, and progressive disease. So non-alcoholic fatty liver disease is thought to represent the hepatic manifestation of the metabolic syndrome, and hence insulin resistance is thought to be the key mechanism linked to steatosis. And NASH is the term used to describe liver changes like those seen in alcoholic hepatitis in the absence of history of alcohol abuse. It's relatively common and affect around 3 to 4% of general population. The progression of disease in patients with NASH may be responsible for a proportion of patients previously labeled as cryptogenic hepatitis cirrhosis. Okay. Obesity, obese type 2 DM with abnormal LFTs, non-alcoholic fatty liver disease. Associated factors can be obesity, hyperlipidemia, type 2 diabetes mellitus, jejunal-ileal bypass, sudden weight loss, starvation. And in features you can see usually asymptomatic. Hepatomegaly can be the ALD is usually greater than AST, and increased echogenicity on ultrasound. And in management you can see the mainstay treatment is lifestyle change, screen for advanced liver fibrosis every 3 years using the enhanced liver fibrosis test, and consider pioglitazone or vitamin E for advanced liver fibrosis whether they have DM or not. So here ALT is typically greater than AST, and for alcoholic liver disease AST is more than ALT, it's 2 times. So you can know that very well. Okay, next will be liver biopsy and abscess drainage. So liver biopsy and abscess drainage, first of all, percutaneous liver biopsy contraindication when we will not do it, and deranged clotting like INR is more than 1.4, and low platelets, less than 60, anemia, bile duct obstruction, hydatitis, hemangioma, uncooperative patient ascites, contraindication. And pyogenic liver abscess management can be drainage, needle aspiration or catheter should always be performed, and liver abscess you can give amoxicillin, ciprofloxacin plus metro, and penicillin allergic ciprofloxacin plus clindamycin. Okay. Hepatitis B. Hepatitis B basics inhibition period for 6 to 20 weeks. It's a double-stranded DNA virus and spreads through body fluids and vertical. Vertical transmission is the most common mode of spread worldwide, and chronic disease in 5 to 10% vaccination available. Complications: chronic infection 5 to 10%, and fulminant liver failure. Complications can be chronic infection, fulminant liver failure, hepatocellular carcinoma, GBS, and glomerulonephritis, polyarteritis nodosa, cryoglobulinemia. So all these are complications.